You started off as an anesthesiologist, then you're now an innovator working with technology. Tell me a little bit about your journey and tell me what got you to commit to tackling the opioid crisis.
So I practiced anesthesia, chronic pain medicine, addiction medicine for 32 years. I guess it's 3 years ago now. I had a heart attack and my heart rate was 10 and I thought I was going to die. So in thinking about my life, I thought about God and how he's given me a set of skills to help people. And my skills are in medicine, helping people with pain or people with opioid use disorder, which is a politically correct term for addiction. In fact, 75% of people don't take their medications as prescribed. And that costs our country, the US, $290 billion a year. And it costs 125,000 unnecessary deaths. So I think there's a way for me to help people with medication adherence.
Dr. John, would love to, for the audience, maybe spend a few minutes in terms of helping them understand the opioid crisis.
So the opioid crisis started when many people thought that opioids were not addictive, but they are addictive. We know through history, through ancient Roman times. And then many people began to get addicted and have opioid use disorder, and many people actually overdosed and died. In the infinite wisdom of the government, they tried to reduce access to opioids. And with people in pain, they become desperate. So the first other thing they went to was heroin. And fast forward a couple years and 1 million lives lost, many people are going to fentanyl. And now there's a new drug called nitazene, which is 5 times stronger than fentanyl, which is now being promoted as the next wave of opioid overdose deaths. When you try to reduce access to opioids, people in pain aren't treated, so they try to go to something else. With the elderly, pain is not predicated upon age or sex or social economic position. You're young, you're old, you get addicted.
And tell us a little bit about the origination of the opioid crisis. And
so the pharma company, they just make opioids. But then, the government, they said that pain is a fifth vital sign, so they told doctors to go ahead and give pain medicine, to give opioids to anyone in pain. In fact, some doctors were sued because they knew and they understood that opioids are addictive. When that occurred, the pharma company said, hey, we can sell this stuff. Many doctors just followed the government regulations and prescribed a lot of opioids. And then the government said, oh, that's a mistake because a lot of people are dying. The government said, okay, we're going to restrict access. By restricting access, you're leaving patients in pain. In fact, in the last 10 years, there's been a 44% drop in opioid prescriptions for acute pain and a 40% drop for patients with terminal cancer pain. So that means we're really leaving patients who are dying in pain without treatment.
How do you think this will get solved in the long term, if at all there is a solution in sight?
I think the pendulum has swung too far to abstinence, but everyone knows that abstinence really doesn't work very well. If you look at Alcoholics Anonymous, their success rate is 6 to 7% with 12 steps and still drink alcohol. What's the same thing with opioid use disorder? 90% relapse rate, quite high, because if you don't use a medication to help you recover from the opioid use disorder, abstinence is very hard to treat because there's a mind component and there's a body component. So withdrawal symptoms are awful. It's like having a really bad hangover. It's like, what do the people do to take care of the hangover? They drink more alcohol. And the problem there is that, with opioid use disorder, there's a treatment. There's methadone and Suboxone, which reduces the opioid overdose death rate by greater than 50%. So now you have abstinence that's successful in 6 to 7%, and you have an opioid like methadone or Suboxone that can save greater than 50%. But because of stigma, because of the issues with cost of treatment, only 11% of people with opioid use disorder get treated.
What has been your approach to addressing the opioid disorder? Would love to also hear a little bit about the ipill dispenser, other initiatives that you're part of.
This sounds very strange, but when I write a prescription for opioids, it's perfect. It abides by FDA, DEA laws and regulations, which means that when I write a prescription, I tell the patient how to take the opioid. But when the patient gets home, there's no restrictions of how many they take. They get a vial of opioids like this. They open the vial with a child-resistant cap, and they can take 1 pill, 10 pills, or no pill. So one day, I was late to clinic, and I saw my patients going from car to car. When he came into my clinic, I asked him what they were doing, and he said, well, you get so angry when our pill counts are incorrect that we just want to make our pill counts line up so you don't get angry. I didn't know what to say. And so I went through the day, and I couldn't eat because I was so fixated on the problem, and I didn't have a solution. And I got out of clinic late evening. I went to the bank to get money to buy some fast food, and I couldn't get money out of the ATM, and I went to my phone app to see why, and that's when it hit me. Why can't we have a mobile app on the patient's phone that takes a picture of them so I know that it's them taking the pill, so only the prescription holder has access to pills? And why don't we have a bank ATM for pills at home so only the prescription holder has access to only the prescribed dose and time? So this is what I developed: phone app and a pill dispenser. So the pill dispenser has several different functions. If you are forgetful, we remind you to take the pills. If you don't take your pill that you need, we notify family, friends, and the caregiver. This device here that is very simple. It's just one door for the thing to come in. There's nothing else on it. Try to break into this, the pills can be destroyed. Now that part is being FDA submitted now. Nice. So we're trying to prevent misuse, abuse, diversion, and accidental overdose. That's the ipill dispenser. You know, I'm really trying to help a lot of people. So even if they don't use the ipill dispenser and they get a vial like this for opioids, what I've done is I've combined an opioid plus a respiratory stimulant. That means that if you take your opioids and you take too many of them, you're not going to die because you're going to stop breathing, because the respiratory stimulant is going to begin to stimulate your breathing in the brain and in the periphery. That means that an opioid that has the most dangerous, fatal side effects treated. We treat constipation, nausea, vomiting, and we treat itching, but we don't treat the one that kills you. Now, with the combination of the opioid and the respiratory stimulant as one pill, you can take it and you can get your pain treated, and hopefully you won't go to heroin or fentanyl or nitazine. And then the second thing is, you know, if you take too many of them, the respiratory stimulant actually stimulates a fight or flight response. People will not like taking too many of the pills. My third company is a combination of Narcan and the respiratory stimulant as an auto injector, so you can inject it right on in your arm or your leg. And the reason for that is because of fentanyl and nitazine. You give one dose of Narcan and they may not start breathing again. You may have to give 3 or 4 doses of Narcan. And in that time, brain cells are dying. The patient may not be able to be saved. But what happens if we have one auto-injector that can restart breathing 2 different ways so that we can be successful on the first injection? So now we can have a device that can deal with Narcan dosing ambiguity.
This very meaningful work, you kind of multiplied in terms of treating one patient at a time to be able to do this for hundreds of thousands sort of a thing, right? Dr. John, would kind of want to just double click a little bit more on medication adherence. I mean, for the kind of people that we deal with, we also know that medication adherence is actually a very important problem that needs to be solved. How do you see technology actually helping on that front?
So the NHS in the UK called and said that we have patients with mild cognitive impairment. These are pre-dementia, pre-senile, and they take 5 to 8 different types of pills. The object there is to make sure they have good medication adherence to prevent the progression into dementia or senility. You can use AI to help you design a pill dispenser like this that can dispense 5 or 8 different types of pills. Because you know, even it happens to me, as I get older, I may be holding a pill in my hand in front of my pill box, and I'll say, did I take the pill just now or did I not take the pill? We actually videotape the patient taking the pill. That's number one. The doctor review it to make sure that that patient is taking their one single pill or 5 different types of pills. And then we can also put a small little transmitter on each pill. When it hits the stomach, it sends a small signal that can be picked up by the phone.
Wow.
So that kind of technology can really help us improve medication adherence.
From a policy and both around innovation, around opioid control and other areas, what kind of policy changes do you think can actually help in driving better health, driving lower opioid deaths, help influence medication adherence?
Yeah, well, I think it's really education and understanding of the problem first, and then targeting the right problem. In the opioid epidemic, we started off with prescription opioids causing the majority of deaths. In 1999, there were 3,300 opioid overdose deaths, 0 fentanyl overdose deaths. In 2023, there were 13,000 prescription opioid overdose deaths and nearly 100,000 fentanyl overdose deaths. So fentanyl is illicit. Really, our target is not doctors or prescription opioids. Our target should be illicit fentanyl, preventing the smuggling of fentanyl into our system. I think that's the first thing to understand. And the second thing is, if we don't treat more patients, we can have a problem. Right now, today, it costs our country, the United States, $2.7 trillion for the opioid epidemic and 100,000 lives. So let's say we use the ipill dispenser and save 10%. That's $270 billion a year we can save, and 10,000 lives. So the policy change that needs to occur is that we need to get people to understand that prescription opioids are a very good way to treat acute pain and terminal cancer pain. We should make sure that the patient is only able to get drugs at only the prescribed dose and time. In the hospital, opioids are triple locked. Well, this is technology where this is a nurse, and the nurse is giving you your drugs only at the prescribed dose and time. This device can save lives and save money, but people don't want to pay for it. The insurance companies, they require data. They require return on investment. So we're going to people who really need it. And the opioid litigation settlement funds, billions of dollars, can help. We are using the ipill dispenser when jail detainees who get released on parole early, they get a couple dispensers and then are driven to an OUD clinic. 85% of jail detainees have an opioid use disorder, and they're not treated. Now jails are starting to treat detainees because if you don't treat them, in 6 months, 75% will be reincarcerated. That means that if we treat them and we continue them on treatment, we can reduce the overdose deaths by greater than 50%. So the policy changes I'd like to see are that we direct our efforts towards illicit fentanyl. We treat as many patients as we can. We pay for that because, there's a tremendous amount of human suffering with opioid use disorder. Not just the patient, but the patient's family.
Dr. John, at some level, there is just insufficient allocation of resources and funds towards this crisis, primarily, right? And then there is policy changes that need to happen around that.
There's a lot of money out there. Every state in the United States has or opioid litigation settlement distribution committee. There's billions of dollars sitting in the bank they don't know what to do with. We're trying to get it out there, to get that money to go to the jails so they can, treat patients in jail and then treat them when they get released with the ipill dispenser so that they can get drugs. We're trying to do it at as low price as we can. There's a pharmacy that in their settlement for the opioid has put in their bylaws that they need to donate 50 million pills as reparations for their contribution to the opioid epidemic. We can try to use those pills to save lives and have no cost to the patient. And how great is that?